Hi everyone, this is Dr. Riley from Attune Health. I wanted to talk to you today about a condition that I encountered in the clinic and is also getting a little bit more news in the rheumatology world, which is polymyalgia rheumatica. It sounds like a mouthful, but polymyalgia rheumatica is an inflammatory condition that we see affecting structures around certain joints, so like the tendons and also fluid-filled sacs known as bursa. So it's a condition that tends to affect the neck, the shoulders, and then also areas of the hips. And we tend to see this condition in patients who are over the age of 50. It's relatively uncommon, but it is something we definitely do encounter in rheumatology. We see it more commonly in women than men, and again, it tends to be in patients who are over the age of 50, most often patients who are 60, 70, sometimes 80 years of age. How does it typically present? So it can be sort of an insidious onset, meaning that it can occur over the course of several months. But there are a number of patients who will really recollect the very specific day when they develop symptoms. And again, the symptoms that people can get are very severe pain, aching, and stiffness that predominantly affects the neck, the shoulder girdle area, as well as the hip girdle area. Sometimes patients can also get pain and swelling of the joints, although that tends to be a less common presentation. When you come into the office and we examine you and we're considering this condition, we would do a full physical examination, essentially looking for signs of inflammation and swelling, because some of the other symptoms that you may experience would be symptoms of very debilitating fatigue and just generally not feeling well. Sometimes people can also have fevers as well. So we would examine you and ask you questions related to that. If we were thinking about certain blood work, usually what we would do is look in the labs for any evidence of inflammation in the blood, and those tend to be markers like what's called the sedimentation rate, or the ESR, as well as a C-reactive protein, or CRP. And in most patients who have polymyalgia rheumatica, these labs tend to be elevated. We may also see anemia, and the platelets on your blood counts may be elevated as well, which can all be features of inflammation. Other things that we may consider doing would be imaging tests, and that can range from doing an ultrasound to look for evidence of those tendon inflammation known as tendinitis, or inflammation of the bursa sacs called bursitis. So sometimes an ultrasound can be helpful for that, but other studies that we may consider might be an MRI, and even PET CT scans are being used now more to help diagnose this condition. Now, as far as treatment and prognosis is concerned, our first-line therapy for polymyalgia rheumatica has historically and continues to be low to moderate dose steroids, which is generally in the form of prednisone. Oftentimes we tend to start at a moderate dose, which is anywhere from 15 to 20 milligrams, and this can be both a therapeutic intervention, but it can also help us with the diagnosis, actually, because a characteristic feature of polymyalgia rheumatica is that we may see a very dramatic improvement in patients' symptoms within a matter of a day or two, sometimes after starting prednisone. And so that can actually help us really sort of key in on the diagnosis. Now, in terms of prognosis, ideally our goal is to get patients off of prednisone and off of steroids as quickly as possible. But generally, in about half of cases, patients may be able to get completely off of prednisone. Generally, this tends to be over the course of many months, sometimes 1 to 2 years. So it does take a little while to kind of lower the dose, because in about half of cases, what we see is that patients can have recurrences of their symptoms, or they can relapse. So more recently, we have been working in the rheumatology world about about identifying medications that can help us reduce steroids or potentially get patients off of steroids as quickly as possible, given that they have many different side effects associated with them. A medicine called methotrexate has been used in the past. That's usually an oral or sometimes an injectable medicine. But more recently, there have been studies that have looked at biologic medicines, looking and identifying IL-6, which is an inflammatory protein in the blood, or what's called a cytokine. And there are two biologic therapies. One of them is a medicine called Actemra or tocilizumab that has been used. And more recently this year, there was a large clinical trial looking at, well, relatively large in this disease entity, looking at a medicine called sarilumab or Kevzara, and it showed improvement in patients, that they had greater rates of remission in comparison to steroids alone, and that it helped patients have lower doses of steroids as far as a cumulative dose. So there are some promising therapies that are starting to come out for this condition to help treat it effectively. Again, it is a rheumatic disease, so you would follow with a rheumatologist like us for the foreseeable future, and we would be there with you to help treat you along the way. So that's all I have for today. If there is any other questions, we are happy to answer them, and otherwise we will see you in clinic. Thank you.